My name is Priyanka Surio. I'm the current Director for Data Analytics and Public Health Informatics at the Association of State and Territorial Health Officials. That's ASTHO for short. And today we're going to be exploring a panel where we're going to be joined by professionals and experts across a multitude of various organizations to include Direct Relief, the World Health Organization, and the U.S. Department of HHS, Health and Human Services. And amongst all of our panelists today, they have many decades of experience and provide really unique insight into how we responded to COVID-19 and have responded to other large-scale pandemics in the past. And just to give you a bit of context as to each of our panelists today, we'll be joined by Robert Shankman. He's the Chief Geospatial Information Officer for the Office of the Assistant Secretary for Preparedness and Response at HHS. We also have Andrew Schroeder, who's the Vice President of Research and Analysis at Direct Relief. And then we are also joined by Ravi Shankar, who is the Technical Officer for the World Health Organization here today. And again, just to give you context, we'll be speaking about leading a large-scale response, a large-scale pandemic response, and through the context of using location data to help improve that response and our understanding of the pandemic itself. And this is a particularly important topic for ASTHO and for our health officials and their respective leadership within the health agencies, because many of them have recently been utilizing or have been developing processes around institutionalizing the use of geospatial information systems and technology to help inform response, resourcing, and track disease spread in various environments using that location data and geographical information. In fact, as we were exploring the utility of GIS and other tools in that way, we were able to conduct a survey of many of our health agency leaders and learned that many of them were using either desktop or web-based geographical information system tools, and that there were a broad array of users for web platforms, but not so much for in-depth desktop or mobile applications in that way. And so it began to show a distinction between level of comfort across just even platforms. We also found that there were a couple of states that were in the planning phases of learning how to integrate some of their other data sources and information systems with a GIS tool, whereas another group of states were more in the operations and maintenance phase of this and already had several pilots underway. And so we saw equal amount of spread of those capabilities across the board from our states. And then last but not least, when we talked about and asked about what states were using or planning to use to map out electronic health information with environmental health information, we learned that many of them are using ArcGIS. In fact, that was of the 33 states that we surveyed, that was 33 states. But we also learned that other tools such as Tableau, Google Maps, and the programming language of R were also used for a number of the other states as well, in conjunction with some of their GIS tools. So while that gets into the weeds of different tools that might be used for response, again, this is a growing area for many of our membership, and we look forward to hearing from our panelists today on how they too have assessed the needs of their respective organizations, adapted their approach to COVID-19, and have specific lessons learned and practices that they can share today. So without further ado, I'm going to turn it over now to Rob Shankman, who will talk about the national level response from HHS. Rob?
Great, thank you. Yeah, so on a national level, when we first started kicking off our COVID response, which was January of 2019 or 2020, right at the end of 2019 into 2020, we were really at that point looking at repatriation of US citizens coming off of cruise ships. And so at that point, it was a very small local response for us. And so we took care of it as we do for normal small local responses, and noticed that it wasn't slowing down, it was picking up speed. And at that point, we determined that we needed to spin something up larger. So we've been integrating some of the geospatial displays that come with the Esri software. So we've been running with dashboards, we've been running with file geodatabases and sharing out the data to our, at that point, very few partners for those partners being, say, FEMA and DoD, and we would share out our data REST endpoints. As the event evolved, it changed what we did and how we did it. So we were looking for different sources. We found new sources coming directly from hospitals. We normally don't have that kind of visibility. Normally hospitals are covered by the states or by the local governments, and we don't get that kind of visibility. And now we were getting introduced to new data sets that were giving us granular level information about facilities individually, and had to incorporate that into our system. We also had to look at how were we going to satisfy the needs of normally how we communicate and partner up with, say, a half a dozen or even a dozen agencies. This event started to grow at an exponential rate, requiring us to go from, say, about 300 users to 5,000 users, from about a dozen agencies to about 40 different agencies. So it was an incredible growth for us. At times we stumbled. There were times when our system came crashing down, and we brought it back up, learned our lessons on how to build an expandable and extensible system. And we have succeeded in all of our endeavors. So we now serve out daily updates at a granular level down to the facility, to federal and state agencies. We do not serve this. A lot of this data is proprietary. A lot of this data comes from hospital networks that don't want to share it outside into the public. They're perfectly comfortable with data use agreements for sharing it within internal federal agencies to help them help their constituents, but they are not comfortable sharing it outside there. So we've shared it with many federal and state agencies, and they're using it and incorporating that information into their meaning the other federal agencies on how they're going to return to work. What's their workforce population that could potentially be impacted? So they're utilizing all of this information that we're gathering that we never had access to before. So that's really how it's grown. We've started from a small, it was really just a couple of port cities, and we were moving people around by airplane, to what it's expanded to now with multiple community vaccination sites, tracking vaccine, tracking vaccinations in terms of population, tracking vulnerable population data sets. And I know Andrew's going to get into that, so I'll leave that part alone, but we're tracking that as well. So to make sure that we're all looking at the same data sets and the same people and coordinating that within the federal agencies.
Thanks so much for that overview, Rob. And I know we'll delve a little deeper into some of those data sources and how you collected that data later on. So next, nice segue into turning it over to Andrew from Direct Relief to talk a little bit more about their specific use case in terms of the response and how they worked across the national and the global scale.
Thanks, Priyanka, and thanks, Rob. So just a little word of background about Direct Relief. We're a nonprofit organization headquartered in California. We work globally in 90 countries, as well as throughout all 50 states and US territories. And we got involved, we're principally a humanitarian logistics organization. So the role of Direct Relief is to meet the needs in the healthcare safety net throughout the world for access to essential medicines and medical supplies. So this ended up being by a huge margin, the largest response that we've ever undertaken, in particular because of the role that shortages in healthcare goods played across, especially the opening months in the first wave of COVID, but really throughout and up until the current emphasis in many parts of the world on access to vaccines. So we got involved in response to the COVID pandemic in January of 2020 through networks of doctors that were connected to medical facilities in Wuhan, China. We were having to repurpose supply of N95 masks and other personal protective equipment that actually were originally sourced from China back away from wildfire response in Australia, back into pandemic response in China. And so the first kind of key use of geospatial technology in that context was to actually fairly simple, but to just geolocate all of the facilities that we were working with. We don't normally have a humanitarian response capacity in China, so we had to scale this quickly, ultimately to 50 different institutions across 4 cities. We have to be as maximally transparent as possible about the requests that are being made. So, and the requests that are being fulfilled. So we had to track inventory information that was then put on maps to be able to show the donor public, our suppliers, and any other kind of interested parties, including the press that was very interested in information about the emergency right from the get-go, as to where exactly, how much, what kind, what were the kind of particular PPE needs that were filling certain gaps, and what's the population affected in those areas. And as that kind of moved then across the world to Iran, to Europe, and then eventually into areas of the United States. I mean, our first shipment for COVID went to Washington State, King County, in January. The same logistics information applies, but now tracking, as Rob mentioned, really kind of information that was becoming clearer about social vulnerability, medical vulnerability, and the correlates that became really clear about who was most at risk: age, diabetes, other comorbidities that made people much more at risk. Where were the locations of nursing homes and other institutions where the mortality rate was much higher than everywhere else, because the field for logistics, healthcare logistics, expanded fast. Again, nursing homes are not normally where we actually engage humanitarian response. Large scale hospitals in the United States don't normally require humanitarian response, but we had to ultimately supply ICU capacity into places where the healthcare system, like in New York and Chicago and parts of Seattle and other cities, were getting overwhelmed. The key kind of Esri technologies that were really useful at that point were dashboards by a pretty large margin. Integration of the Johns Hopkins data quickly was through web services, I think, was a huge service to everyone, so that as that data was coming together around cases, deaths, et cetera, that was being integrated into our logistics applications quickly. And then issues around those risk and vulnerability factors that we were learning as the research came online became quite essential. Integration into ArcGIS Insights for analysis, so that all of the kind of related data sets that were coming together, as this really was the data response in many ways, were kind of put into an integrated data visualization and analysis framework. And then I guess the last thing I would emphasize as to what was really kind of special about this response was the integration of large scale human mobility data, which really came of age in this response. We had a particular kind of affinity and skill for this based on previous emergency response. There was a high demand to understand social distancing, where social distancing orders were being followed or not followed. These were, data sets provided to track human mobility through Facebook, through Google, through digital adware, aggregated at large scales, to be able to see where people were slowing down or speeding up their response, and that all in a fairly granular time sequence. And then that was provided out through a network of infectious disease epidemiologists and modelers in a bilateral basis with public officials, other health responders, et cetera, to inform kind of the scope of the response. So, that real-time information became, I think, quite distinctive during the COVID response, and the Esri software and analytical packages were pretty key to making sure that all of that fit together as well as possible.
Absolutely. Really appreciate those remarks, Andrew. We'll get into our next speaker here, but to speak to the power of dashboarding, absolutely agree here in that it was very key to getting states to be able to share their own data as well. And we were made aware and even supported the public-private partnership between CDC, Centers for Disease Control and Prevention, and Esri as they were supporting states in building up those dashboards for various data on cases, spread, and PPEs and other resources. So appreciate your perspective here today. And without further ado, we will now turn it to Ravi from the World Health Organization to really set this context of how we've been able to leverage our past experience and lessons learned from other pandemics, and what in particular made COVID-19 so different, in which WHO has now adapted and innovated to address.
Thank you, Priyanka, for this important question. Just to give a brief, I lead the WHO GIS Center at the headquarters here in Geneva. But before this role, I was supporting polio eradication initiative, and I supported many outbreaks and crises for WHO. Just going back on the Ebola response, WHO didn't have a central infrastructure to support the Ebola response in 2016. The whole infrastructure which was built for polio, which was a small scale, was totally geared up to support the Ebola response. With the support from partners like Esri, NetHope, Direct Relief, JS Corp, and others, we had a big fight against Ebola. We also built a small-scale infrastructure for GIS within WHO to manage multiple crises. It also gave us a confidence to build a GIS team within the Emergency Response Department. This is the first time WHO had a GIS team supporting the emergency response. Following that, we had the outbreak of Zika. The lessons learned from Ebola was very useful for us to support Zika, but the challenges were also different. Going from 6 countries to 60 countries was a big challenge for us. Working in multiple time zones and languages were also a challenge for us. And also the Zika response needed a different sort of geospatial modeling. For example, doing a prevalence of the mosquito species and various data analyticals, which was not the same for Ebola response. Then we started contemplating on having a WHO Central GIS Center. By then, we had the big crisis on COVID, wherein we need to pull all the resources from every direction and support from everybody all around the world to support this crisis. We were all stretched. And recently, we started looking into the establishment of the Central GIS Center. Though the emergency response team now is still supporting the COVID response, as it's still not over, we started thinking beyond the COVID response. So we, with UNICEF and co-partners like BMGF, Gavi, Global Fund, and World Bank, started having this working group, GIS working group, to support the COVAX vaccination planning rollout. So we started looking into the use of GIS to have equitable distribution of the vaccines to everybody who are in need. This co-partner group also started expanding its net and having a bigger technical partner working group of more than 40 entities. This gave us the strength now to roll out the vaccine with more confidence. So we are embarking a new area of digital microplans. The only time we did a microplan in our past is in the polio eradication, where we made sure that every child had received the vaccine. But this was for a smaller age group. Now we wanted to expand this to a bigger age group to have people to be able to reach to the nearest health facility, to have outpost and also mobile clinic outside, and to also reach to door for places where for them to reach to the health facility is not possible. The challenges and the needs are different. We are not going to stop here. We are going to bring this digital microplan into the routine immunization, where big outbreaks on measles and other routine immunization work can be benefited on a longer run. Gavi, BMGF, and other partners are really committed to make sure that the investment which we are going to do now for the COVAX vaccine rollout planning is going to reach more than what it is intended for. Thank you.
Thank you. Really appreciate the context that you set with all of those different disasters and natural disasters and pandemic responses in the past. And I think that this is a nice time for us to transition now into our discussion with our panelists here. And so we'll go through a number of questions and discussion prompts that we think will tease out some of the additional lessons that they've learned and practices that they've applied here today. So just to level set for the audience today, I'd like each of you to speak a bit more broadly to what specific geographic data points you used, including where that data was sourced from. And some of you have already mentioned some of this piece in terms of leveraging other dashboards or information sources, but where you can speak to that specifically, that would be helpful, as well as how you decided to display this information or how you decided to use tools to display the information. We'll start with Rob first.
Great, thank you. So at the Department of Health and Human Services, we have a broad range of requirements and a mission, which is the health and well-being of the population of the United States of America and its territories. So we are constantly monitoring that. The difficult piece for us is that we don't own any of that healthcare infrastructure. The Department of Veteran Affairs, they have their own hospitals. They have terabytes of information on their own patients. We don't. HHS does not own or operate any hospital. We don't own and operate any dialysis centers. We don't own and operate any clinic. Yet we're still required to report on those and gain that information. So in the beginning of this pandemic, we were kind of scrambling. We've got the infrastructure as it pertains to its location. We do know where everything is. The difficult piece was the throughput, was the patient encounters, was the treatment, what's their primary treatment in a hospital. We know it's a trauma level 1, that's easy, but truly what is their specialty and how many patients do they see of that caliber? So that was a piece that we had been grappling with periodically throughout all of the other disasters that we managed, but COVID really brought it to light that that is a shortfall that we couldn't overlook this time. So we integrated with HHS Protect, which was a new system put online that was actually built to gather information at that local level, at that facility level. It incorporated their input, and we then had access to that. And we're able to push that back out to those partners that were authenticated to have that access. We've also been pulling data from NGA. So there are 2 data sets that NGA publishes. There's the Highfield Open and a Highfield Secure. And so, the open is publicly available to everybody, and the secure is available to federal and states. So we were pulling all of that information as well. We've got Esri's data, we've got Esri's software. So we gathered all of that information. A lot of those connections had already been made because we do have a lot of disaster experience with hurricanes, tornadoes, earthquakes, floods, wildfires, and everything else. So pandemics, yeah, we dealt with Zika, we dealt with Ebola, so we kind of had a little bit of a taste there, not as much as we had wished, but we were able to incorporate all of that information. So we pushed all that together. We were using dashboards, we were using story maps. We started off our COVID Common Operating Picture started with about 8 different dashboards. It's now up to 75 dashboards. So there are 75 dashboards. There are dashboards that are stacked on top of each other with subtabs. It's gotten pretty intricate. We need 2 staff that are working it, 5 days a week to make sure that the data is updated and everything else. So it's a full integration of multiple data sources that several people have data feeds. Other places just use the dashboards. And so it's been widely accepted on the federal and state level as an authoritative source. And we've worked really diligently to make sure that the data sets that we have are authoritative data sets. and that they're verified. And that's and we've worked on that. And with all of these data sets, there's always this concern that you make sure that what your data is scientifically sound and correct and not being edited. So that's where we are right now. So it's worked out really well.
No, really appreciate that context there, and especially how you used all those various data sets. So Andrew, anything you'd like to add to this one?
Yeah, I think, as I mentioned before, we had to respond, quickly to the changing material needs of all the various, healthcare infrastructure throughout the world that was in need of material based upon shortages. So in the United States, that meant, for instance, having to gather new data about needs from our principal network, which is federally qualified health centers and free and charitable health clinics, to understand how they were being impacted, just because it was unknown. So we used Survey 123 in that context to get survey data out as fast as possible to understand what their PPE needs were, how the staff was being impacted, where they might be missing time as a result of staff being sent home because they actually had COVID, where they might have been at risk of shutting down. This was one of the kind of key issues throughout. As we kind of transitioned into more of the broad-based response effort, integration of demography into our GIS was really probably the forefront of what we were facing. I mean, I mentioned already questions around comorbidities and age, race and ethnicity and some of the other differential impacts that were felt by communities throughout the United States in particular was, I think, one of the most important areas for us to focus on, as it became clear that COVID was not borne equally across the United States. Some communities were much more disproportionately affected, and that kind of differential demographic response became quite important to understand and to plan for in terms of equitable response. And that continues in the vaccination effort now, where vaccines are not necessarily right now distributed equitably across all communities. And understanding those disparities becomes an ongoing need. Just the last piece I would emphasize is around tracking the distribution of material throughout community health worker organizations in Africa, where we realized there was a gap that was faced by those that would interface most directly with communities in areas of Africa that were going to be most likely to get left behind. This is building off of work that Ravi talked about in terms of the response to Ebola and other things, and the ability to link dozens of community health worker organizations together to track material going out to them, and then to show progress towards meeting the targets for how we can resource community health throughout the continent became, I think, really, really essential. And Esri technology was, I think, instrumental at each point in there.
Really appreciate that and bringing up that global use case there. And so I'll turn it finally to Ravi to speak from the WHO perspective, especially in terms of how you've navigated that in working with so many different countries.
Yes, thank you. Great explanation given by Andrew. Just to follow up on that also, that for the COVID vaccination rollout, the key things which we are looking out is to have a satellite imagery, the building footprint on where people live, the location of the health facilities, the roads, and the drive time to the health facilities. So to build this, actually for more than 100 countries, we actually need an army of people to join together. We're looking for sources. Where can we actually find authenticate locations of health facilities? We find sources of health facilities, sometimes the government facilities. Where do we go for the private facilities and clinics and pharmacies? Because we also see that these are extended places where vaccination are to be carried out. So our biggest challenge is to have a central health global registry of health facilities. So that is one. The next one is also the spatial footprints, to have the building footprints overlaid with the population by various age groups. I think this is where the network and partnership is really needed, to have the entire footprint of entire Africa and Asia, South America, associated with the population by age group. So that is where we are requesting our partners to help us to bring all of them together. Some of the tools introduced by Esri for the COVID response and for the vaccination planning is fabulous. We are seeing the whole community coming together, the tools in OSM, the support from Map Action, the support from NetHope. We are all joining together to fight this, and the next pandemic is not very far away. Thank you.
Really appreciate that. And that speaking of using these tools in that way and what you've learned from them really gets to our next question. And, again, as you're thinking about all the ways in which you've used these, I think it's helpful, especially for our former panelists, to speak to what practices and lessons they learned as well from previous disasters and pandemics. And if you could narrow that down to maybe one or two of those practices that you find is transferable across diseases or pandemics in that way, or even disasters in that way, that would be most helpful. And then as you're speaking to that, what new lesson are we now learning from COVID that is different?
Lessons learned is to always be incredibly flexible. The new data that you get will not be as clean and as pristine as you have been led to believe or even think it's going to be. So you need to really be flexible, and then be on top of that, you really need to understand the data, understand the data's limitations, so that you don't derive product that pushes beyond the validity of that data. So if we were tracking PPE, and at one point there were issues with the data that we were getting, and all of a sudden the thought that we had on how to produce this display just kind of came crashing down. It wasn't the system, it was the limitation of the data, that we couldn't produce what we had hoped and thought. So just being really flexible, and the other skill that comes along with that is being able to convey that to your leadership. So they've got a preconceived idea of what they want to see, and they know that you're getting PPE data, or you're getting treatment data. Oh, that's all they hear. And I'm not saying that's wrong, but then they have, again, their own preconceived idea of what you're going to be able to display. So having the ability to have a dialogue with management to understand what that limitation is of the data, if there's any limitation on the software or the display, and working through that. Luckily, at least on the HHS front, we've done a lot of disasters. We do a lot of disasters. I mean, hurricane season happens every year, and last year happened to be one of the busiest ones ever. So we were well versed in how to communicate and integrate new data sets for hurricanes. So that dialogue and that mechanism for the dialogue had already been created. So that was a lesson that we had learned in the past that we built upon. And the lesson learned this year was obviously being very flexible. And then looking forward, we are trying things that we had never thought about before. We're trying things with surveys in the field, using field surveys not only for just gathering data, but gathering information about actual people, like our deployed staff in the field. We've never done that before, but now, wellness checks through surveys and things like that, which we had never thought about. Now we're actually thinking about those things and gathering them, whether or not it's daily or weekly. We're still, broadening our horizons and trying to gather more information about our own individuals that we put in potentially harm's way. And all we had done was sort of send them and then bring them home and check in on them periodically. So we're broadening what we capture. So that's really our future on where we're going for data collection.
Really appreciate that specific
Sure.
example there. Andrew, if you could speak to this.
I mean, I agree with what Rob was saying about the need to adapt to data conditions that are not of your own choosing. To me, the threshold event with COVID and data, particularly GIS, was the need to operate in real time at scale. This is something where, previous disaster responses for us are real time, but they're localized. So it's a hurricane in one or one city or a neighboring region. Or even the Ebola crisis actually was, it's enormous, but it was 3 countries and relatively contained in those 3 countries. COVID was of a whole different order, so it made the data scale that we were dealing with just dramatically larger, and opened up a whole series of issues that we weren't necessarily completely conversant with when the emergency happened. You have to learn quickly. And all of that, I think, to me means that the high level takeaway is you can't be too prepared on the data side. Having models, web services, map templates, survey frameworks already built that you can quickly adapt to new circumstances becomes absolutely crucial, because there's no other way to operate at real time at scale. My second takeaway is just that that's actually going to probably get larger in the future, where there's more diversity in areas that have to be kind of tracked. We have to integrate with surveillance systems in a new way around disease surveillance. We have to be able to integrate modeling in a new way. Often humanitarian logistics has not been completely plugged in with the epi modeling world. COVID really changed that dynamic, where we had to plug in with epi modeling, and my sense is that that's going to be a much more significant area of growth in the future. So integration of epi modeling into our GIS, and then integration into our logistics systems, I think is going to be really key. So yeah, those are just a couple.
Great. Thank you for previewing that future work for us. And Ravi, if you could wrap us up with this one.
Yes, I think I can take an example which is nothing related with crisis. Let's take about a snake bite. I don't know if people are aware that once in 5 minutes somebody dies somewhere in the world because of a snake bite. What is the relation between this and the lessons learned from COVID response? So the locations of the health facilities with the availability of antivenom is the key to save somebody from a snake bite. Actually, we are learning lessons from here, and we are trying to transpose that into multiple countries in Africa. This is a new project to our center, which is funded by Wellcome Trust, where we are seeing synergies between these two. So the request there is for somebody to know which is the nearest health facility should I go for a snake bite, after the snake bite, and then what are the various antivenoms which are available at that, so that I can be going to the right location, or I can be redirected from that facility to the right one. So we see that the lessons learned from mapping the health facilities and having more information about the health facilities can be actually moved to a non-pandemic or non-outbreak situation where WHO and multiple organizations can benefit from that. Thank you.
Thank you. And that's a very nice segue into our last question for today's panel discussion. Part of being able to maximize resources and address a pandemic at a large scale is working with so many partners and stakeholders. And so as we delve into this question, I encourage each of you to think about who all you worked with. And to answer this, really speak to what stakeholders did you engage or work with to maximize the utility of your platforms, of your data, and how can we better coordinate that in the future, especially across many sectors such as healthcare, technology, public health, response, and preparedness? Anyone can answer.
Yep. So I'll give you mine, which will be really rather short. We've always been engaging with all of the federal partners. So that stems anywhere from FEMA, FDA, NIH, CDC, and then beyond HHS's realm. So we'll engage with USDA for wildfires. So we've already had those connections. The state and local connections, which is what we've created now with COVID, those are the ones that we didn't have before. So we're grateful for creating those. And the methodology that we used, obviously was the Esri technology that we've got. So, working with them, they helped us fine tune our system as we saw performance degradation and then the requirement to build it out. We worked with them. They worked really well with us, got us what we needed in the time we needed. So that collaboration actually was an additional boost for our system. And so between those, we've succeeded and moved forward, and we'll continue to do that.
Thank you.
In addition to the colleagues on the call here, both of whom, in terms of their agencies, we've been happy to collaborate with where it's appropriate. I would really flag that the role of the academic community actually as a key stakeholder. Particularly in COVID, the academic community has done a really just crucial work in terms of rapid research, modeling, preprints on publications. A lot of that has data that's been opened and made available and is available to integrate, and the amount of learning that's possible to do through academic partners, particularly in the epidemiology community, but really broadly has been crucial. And then I'd really like to emphasize the role of state in the United States, in particular, of state and city governments that often don't get the credit that they deserve in some of these cases because they're not necessarily at the front lines of kind of thinking about. But in this case, like the role of governors, of mayors, of municipal health departments, given the distribution of this really everywhere, all at once at various points, is really important. And for us, working with the safety net becomes crucial. Like we work with community health organizations throughout everywhere in the world. We rely on them for information. We send them material, and making sure that information flow is what makes their material flow as useful as possible is really the heart of what direct relief does. So that I think is something that was true in COVID and will continue to be true throughout all of our future responses.
Thank you so much, Ravi.
Yeah, quickly on our side, moving away from our normal players, actually during this COVID response, we had a Tech for COVID initiative where a lot of public-private partnership came together. Big organization entities like Microsoft, Google, Facebook, Esri, all of them are actually joined together. We are learning a lot from them. We are actually thinking that this would be the new direction for us to support any crisis, and the tools and the offerings which they have is not something we had been thinking about in our normal workflow, like chatbots, machine learning, translations, the power of computing like Azure Cloud, all these things which is slightly new to our normal workflow. I think this is where the multiple stakeholders and engagement for a UN agency like WHO would be moving forward. Thank you.
Definitely appreciate that and would agree that much of this has brought up new requirements for health agencies to consider in adopting them in their workflow as well. So appreciate everyone's comments today. And thank you to our audience for joining us at this panel presentation.